ACE inhibitors and ARBs are among the most prescribed drugs in the world. They form the backbone of treatment for hypertension, heart failure, diabetic nephropathy, and post-MI care. But to use them well, you need to understand exactly how they work and where they differ. Today we break down the renin-angiotensin-aldosterone system, RAAS, the mechanism of both drug classes, their clinical indications, side effects, and the pearls that separate a good clinician from a great one. The renin-angiotensin-aldosterone system, RAAS, is a hormonal cascade that regulates blood pressure and fluid balance. It begins in the kidney. When renal perfusion pressure drops from volume depletion, heart failure, or hypotension, juxtaglomerular cells in the afferent arteriole release renin. Renin cleaves angiotensinogen, a liver-derived protein, into angiotensin-1. Angiotensin-1 is then converted to angiotensin-2 by ACE, angiotensin-converting enzyme, primarily in the pulmonary vasculature. Angiotensin-2 is a potent vasoconstrictor. It binds AT1 receptors on blood vessels, causing vasoconstriction, which raises blood pressure. It acts on the adrenal cortex to release aldosterone, which causes sodium and water retention in the kidney, further raising blood pressure. It stimulates the pituitary to release ADH, increasing water reabsorption, and it promotes cardiac and vascular remodeling, hypertrophy, and fibrosis through direct trophic effects. ACE inhibitors block the enzyme that converts angiotensin-1 to angiotensin-2. Without angiotensin-2, you get vasodilation, reduced aldosterone, less sodium retention, lower blood pressure, and less cardiac remodeling. Common ACE inhibitors include lisinopril, enalapril, ramipril, captopril, and benazepril. They all end in pril, easy to recognize. ARBs, angiotensin receptor blockers, work one step downstream. Instead of blocking ACE, they block the AT1 receptor directly. Angiotensin-2 is still produced, but it cannot bind its target. The result is the same: vasodilation, no aldosterone release, no vasoconstriction. Common ARBs include losartan, valsartan, irbesartan, candesartan, and olmesartan. They all end in sartan. The key clinical difference: ACE inhibitors also block the breakdown of bradykinin. Bradykinin is a vasodilatory peptide normally degraded by ACE. When ACE is inhibited, bradykinin accumulates, causing the classic dry, non-productive cough in about 10 to 15% of patients. This is the most common reason patients switch from ACE inhibitors to ARBs. ARBs do not affect bradykinin, so they do not cause cough. However, both classes can rarely cause angioedema, a potentially life-threatening swelling of the face, lips, and airway. This is also bradykinin-mediated for ACE inhibitors, but can occur with ARBs through an incompletely understood mechanism. Never re-challenge with the same class after angioedema.
Clinical indications for ACE inhibitors and ARBs overlap significantly. In hypertension, both are first-line agents, especially in patients with diabetes or chronic kidney disease, where RAAS blockade provides renal protection beyond blood pressure lowering. They dilate the efferent arteriole preferentially, reducing glomerular capillary pressure and slowing progression of proteinuric kidney disease. In heart failure with reduced ejection fraction, ACE inhibitors, particularly enalapril, lisinopril, and ramipril, have landmark mortality benefit proven in consensus and solved trials. ARBs like valsartan and candesartan are used when ACE inhibitors are not tolerated due to cough. The combination of ACE inhibitor plus ARB is generally avoided. It increases adverse effects without additional benefit. Post-MI, ACE inhibitors reduce ventricular remodeling, prevent progression to heart failure, and reduce mortality. Ramipril showed significant benefit in the HOPE trial, even in patients without reduced ejection fraction. In diabetic nephropathy, both classes reduce proteinuria and slow decline in GFR. ACE inhibitors are preferred in type 1 diabetes. Either class is appropriate in type 2. They are the standard of care for any diabetic patient with microalbuminuria. Key adverse effects beyond cough and angioedema: hyperkalemia from reduced aldosterone activity. Use with caution in patients with CKD or those on potassium-sparing diuretics. Acute kidney injury, especially in patients with bilateral renal artery stenosis. By dilating the efferent arteriole, RAAS blockade drops GFR in kidneys that depend on high efferent tone for filtration pressure. A rise in creatinine of up to 30% is acceptable and expected. Greater rises warrant discontinuation. Teratogenicity. ACE inhibitors and ARBs are absolutely contraindicated in pregnancy. They cause fetal renal dysgenesis, oligohydramnios, pulmonary hypoplasia, and fetal death. This is a Category X consideration. Always screen for pregnancy before initiating. Do not combine ACE inhibitors with ARBs. Do not use with aliskiren in diabetes. Monitor potassium and creatinine at baseline and after initiation. These are powerful, life-saving drugs. Used correctly, they protect the heart, kidney, and vasculature for decades. Subscribe to Medical Sciences Unfolded for daily deep dives into pharmacology, clinical cases, and the science that drives medicine forward.